talked about this a little bit. So Parkinson's is a medical condition that leads to a variety of movement disorders that can limit your patient's quality of life. So if you noticed on the slide before, it says it's a degenerative disease, okay? So with Parkinson's, your patients are not going to get better, they are going to get worse, okay? Remember when we talked about the substantia nigra and how when it loses its color, the darkening of it, that's when we get a decreased dopamine production, and that's when you get Parkinson's. And some of those symptoms that can happen in Parkinson's is bradykinesia, which is what? Yes. So brady means slow, right? Kinesia means movement. So slow movement. And it's extremely slow. So then there's rigidity. What does that mean to y'all? A rigid posturing.
Really stiff.
So what do you think's happening there? Why would that be? What would happen with rigidity?
The muscle neurons firing like non-stop.
That coactivation, right? We're firing, our agonist and antagonists are working against each other, right? So you see that rigid movement. And so a telltale sign of Parkinson's is cogwheel rigidity. So that's when you ask them to lift their arms, and as they lower them, they cogwheel down. Okay? So resting tremors are pill rolling tremors. You'll see the pill rolling in the fingers. Literally, because you could roll a pill in your fingers. That's why they call it that, pill rolling. And remember, we talked about intention tremors, where you intend to go to something and you get a tremor doing that. It's opposite for Parkinson's. You have resting tremors. So as you are at rest, you have tremors. Okay? What about festinating gait? What is that?
They have trouble like starting.
Yes. And it's really small, rapid movements of their feet, right? To get started. And then they have what I like to call freeze frames. They get frozen, right? They can't progress forward. So all of these things are things you're gonna see with patients that present with Parkinson's. Now, do they have all of them? Some of them may not have all of those symptoms. Some may have some of them. And they may not be diagnosed with Parkinson's, okay? They may be diagnosed with a Parkinsonism, right? Which they present with some of the symptoms of Parkinson's, but they don't have all of them, and their neurologist has not diagnosed them with Parkinson's.
So like I treat a patient in my clinic that is diagnosed with like the Parkinsonian symptoms, but they had diagnosed it with Parkinson's first and then called it a misdiagnosis and said he just had the symptoms. So where do they like, how do they like determine that? Like they just don't see it in the brain for it not to be Parkinson's?
So with Parkinson's, it's more of like a cancel everything out before you diagnose that. I think from what I understand, it is difficult to diagnose in the sense that they don't have a great picture of the substantia nigra when they do like scans. So they can't quite make that determination. But my experience is I've had several patients that have Parkinsonisms that do not have a Parkinson's diagnosis. Whether or not your responsibility at that point would be to let your PT know that you see Parkinsonisms in this patient, which they probably have already picked up on, to be honest with you. And then communicate that to either a neurologist or their PCP. Because even if they have a Parkinsonism, that doesn't mean that they maybe are not developing Parkinson's. So that's something that their neurologist needs to weed out. But yeah, there's no specific criteria that you have to follow up to in order to get that diagnosis. It's more of a weed out. Let's weed out all this before we say this. And then you'll see, I've had a patient that has a Parkinson's diagnosis and is taking medication to treat Parkinson's, but then they get two different opinions and two different neurologists tell them two different things. So one agrees that they have it, one doesn't. So honestly, it's but you just tell them what the symptoms are, and a lot of times I don't come out and tell a patient they have Parkinson's, but I do tell them hey, you present with some Parkinsonisms, you have some symptoms of what Parkinson's looks like. That's something that you definitely want to pass on to your physician. Okay. So what are some physical traits that they can present with? They can have increased thoracic kyphosis and decreased lumbar lordosis. So what do you think that looks like? Yeah. So some patients will feel as if they're losing their balance posteriorly and exaggerate rebounding anteriorly. This means that the patient becomes a fall risk. So typically what I see a lot of times, so your book says they'll rebound anteriorly. That means that they're overcorrecting for a postural instability, right? So when they stand up, they're gonna lean back into their heels and then they overcorrect by coming forward too much, making them tumble. But from my experience, as Parkinson's progresses, they don't rebound. They just push back. Continually, hard. It is hard for them to come forward. It's hard for them to push up from a chair. It is easier for them to pull, okay? That's my experience with Parkinson's patients. Now this may be in earlier stages where I don't have as much experience. So they may try to overcorrect in the beginning for postural instability. But as it progresses, they have that retro lean, the posterior lean, where they're rocking back into their heels. Or retropulsion is also called that. This instability comes from delayed motor response due to impaired pathways. So if they're not getting information to where they need to in a reasonable amount of time, then you can see how they would either overcorrect and they're not getting the correct information. Their brain is not receiving the right information. So the output is going to be not correct. So it's a progressive degenerative disease of the basal ganglia. So this refers back to what we talked about in brainstem, okay? So the primary treatment is they do give these patients there's different drugs, but carbidopa levodopa Cinemet is the most commonly given medication. It is replenishing the supply of dopamine and slowing the progression of the disease process. There are a couple of other second generation drugs, which means they came out after the first Permax and Mirapex. This is dopamine agonist. What does that mean? If it's an agonist, what is it gonna do to the receptor?
Fire it, help it.
Help it, right? So most of the patients that I see is they're on Cinnamon. It's typically not called that. They'll say, I'm on that, some of them have the funniest names for it. I'm like, carbidopa levodopa. They're like, yeah.
So, is there any connection between, like addiction and Parkinson's because of the dopamine deficiency that occurs with addiction?
I don't know the answer to that, but I don't see why it wouldn't necessarily be. It could be more of what you're seeing as basal ganglia impact from drug or alcohol use. So yeah, they're producing some of the similar symptoms of what Parkinson's looks like, but not necessarily the same. And I put a picture up here. I try to put pictures. This one was hard to put pictures in. Oh, also, this is a good one. So outside of rigidity, they may have a hard time swallowing. They can't produce a loud voice. So when you talk about working with Parkinson's patients, have you heard of big and loud? Okay, so you always want to tell them big movements, take a bigger step, be pronounced with your movements, move large movements, like over and over, because when you're given those,
Like LSVTB?
huh?
Like LSVTB?
Yes.
Yeah.
So, and then big, pronouncing big sounds, speak up, speak louder. So Parkinson's disease has different stages that we kind of talked about it as it progresses. So in the early stages, it is unilateral to bilateral extremities, and intervention should focus on preventing immobility and include providing encouragement and resources for participating in exercise classes. So when someone's first diagnosed with something, what do you think they need? Education, right? They need to know what's going on with them in their body. And then you need to encourage them to be active, okay? And to continue to move despite their issues. So the patients in the middle stages will actually need some help with their activities of daily living. They'll have impaired postural stability that will lead to motor issues and falls. So the goal of interventions in this stage would be to improve ambulation safety, balance, and reduce risk of fall. You may have to provide this patient with a cue or encouragement for motivation to participate, because Parkinson's can also impact their affect, okay, and their motivation. So giving them encouragement to participate is going to be important. In late stages, the patient is significantly debilitated and will typically be wheelchair dependent. During this stage, you're going to focus on skin breakdown and contractures, family education. And why would you do that at that point? Yes. family's gonna have to take over care and the caregivers. So, they'll have to train on proper, bed and wheelchair positioning and the range of motion exercises required to keep their joints, stable. No hypermobility or contractures. Any questions about that? Seems pretty straightforward, right? But as it progresses, you have to do what? Are we working on remediation? No. We're helping them compensate for their deficits, right? We're making things as easy as possible for them in their environment. Yeah, because they're gonna continue to progress. So remember the Sarah study that I showed you? So this is a typical piece of equipment that I use with people that have Parkinson's, because they can pull themselves up, okay? It gives them more independence for longer, okay? Can you imagine what it's like to watch an advanced patient with Parkinson's pivot? It's actually very scary. It's very unsafe at times. So that Sarah study can give them the independence in order to not have to pivot, but they can still have that mobility of standing. Because you want them to keep certain aspects as long as they possibly can, right? So a lot of times that is an option. Then there's these Walter laughs and calls them stripper poles, but there are poles that you can install next to someone's bed that helps them pull up to the side. And a lot of Parkinson's patients, we will recommend that they can get those as well in order to help pull them up to the side of the bed safer, and without having to have as much assistance. So it decreases burden of care, right? So at this point, we are working to decrease the burden of care on their family and loved ones. So a lot of my goals, when I don't put them to be independent or to be back to their prior level of function, I'm putting in order to decrease burden of care, okay? Because that's what we want to do at the end of the day, is not to unlift some of the burden that their family is experiencing, whether that be through equipment use, like the Sarah, which is quite expensive, but on Amazon it's about $500 or $600, and you'd be amazed at what someone would pay in order to take care of themselves and their back. We've had so many patients buy them, and we've even put them together for a lot of the families, and it's given them more independence. They can roll into a bathroom with that, and it gets through tighter spaces, and it gives them the independence that they need to get things done. But yes, balance is a good thing to work on with these patients, especially in the middle and early stages. Okay, moving on. Huntington's. This is not in your book, but it is possible to see it on your board exam. So, it is also another degenerative neurological disease. This is a neurological disorder that impacts the central nervous system and can cause degeneration and atrophy of the basal ganglia and cerebral cortex. So what you'll see is the etiology of it is that it's a genetically autosomal dominant trait. You know what that means?
If you carry
The dominant trait for it. You're at risk of developing. Yeah, but a lot of times that would mean that at least one of your parents would have to carry that gene in a dominant form. That'll give you a 50% chance of passing it on to an offspring if you carry the non-typical gene. So it impacts people between the ages of 35 and 55 years old, although symptoms can develop at any age. Those are just the more typical ages that you'll see it. Some of the symptoms are affect dysfunction. So, what is affect? Huh? What is your affect?
It's the feelings, sensory.
No,
What?
affect is your facial appearance, right? So like your affect is your mood. So your face appears you have very low emotion in your face. You have poor affect, inability to show emotions through your face. Cognitive impairment. So what happens is they can have issues with cognition. They have involuntary choreic movement or choreoathetoid movement. So a couple of these videos down here show you what that movement looks like. Okay, so it's a movement disorder. They have mild alterations in their personality, and they can have depression, dysphagia, which is what? Swallow, yes. Incontinence, immobility, and rigidity. So do you see a common theme here when we have this involved? We have this and we have this, right? So let's see what I've got here.
My name is Jim. Growing up, I was short and athletic, upcoming recovery. Now I'm 34 years old, and I have Huntington's. I father passed on from HC in 2008. My sister is in the late stage of HC. HC is the worst disease I could possibly have been given. HC is taking everything from me. My cognition, my personality, my ability to drive and exercise. I can no longer work, and he lost the ability to go home myself. There's no cure, but there's hope. In the battle against HD, no one fights alone.
So remember that 50% chance of passing it on to your offspring.
Family is everything.
Sorry, I just wanted y'all to see the movements. It's sad. Now this is a professor. This is when I was growing up, like I couldn't believe what he does.
As opposed to the hypokinetic gait, we now have the hyperkinetic gait, which we see what we call a choreiform gait, or chorea. With this gait, there are not only abnormalities in the gait itself, but associated movements. There can be oral facial dyskinesias, in which the patient will be having movements at one side or the other side of the face, kind of a grimacing type of a fashion. There can be movements in the upper extremities, and there are fragments of semi-purposeful type of movements or writhing type of movements. And then the legs will also start to go. And so the patient attempts to walk with the superimposition of the movements, but the patient doesn't actually fall because the balance is not affected. Just you have these involuntary movements that are now being superimposed on a gait. Now I'd like you to run, like run on a tightrope with 1 foot.
Okay, so that kind of gives you an idea of what chorea looks like, chorea movement. I thought this was an interesting picture of what a brain with HD looks like versus what a normal brain looks like, and the atrophy that's seen there from the degeneration. So next, amyotrophic lateral sclerosis, and most of you know this is ALS, okay? It is a degenerative neurological disease. So, first let's talk about what this means. What does A mean when we talk about without, okay? Trophic. Yeah, trophic changes, what are those?
Strength.
Nutrition.
Yeah.
Yes, nutritional changes, right? What is, so lateral means, you remember that lateral corticospinal tract that you learned that carried most of the movement in your body? That's what that means. Sclerosis. What is sclerosis? What if something has sclerosis? Thickening. Yes. The tissues. Hardening. So now you know exactly what it is, right? From breaking down the name. I want y'all to be able to do that on your board exam. If you see something that's like, I don't know what this is, try to deduce it from what the components of it mean, okay? So with ALS, also known as Lou Gehrig's disease, it's the most common progressive neurodegenerative disease affecting adults. It is the progressive neurodegeneration of motor neurons in the brain and the spinal cord, specifically in the lateral corticospinal tract. Some of the clinical signs are fasciculations, which are not always clinical, right? Muscle cramps, fatigue, weakness, and atrophy. So the common onset is for it to begin in your lower extremities and move to your upper extremities, and it to be bilateral, okay? But another onset, there's different types of ALS, but another onset is a bulbar onset. When we say bulbar, we think of things in our face, head, and neck, okay? And these are the muscles that are impacted there. So you may see a bulbar onset where you see the symptoms onset in the face, in the head, and the neck, not in the limbs as much. It starts here. So about half of people with ALS die within 14 to 15 months, which is pretty flippin' sad, if you ask me. The onset is rapid, and a lot of them will die from respiratory failure. Okay, so with ALS, it progresses in phases and in stages. So with phase 1, there are 3 stages. You have mild weakness or complaints of weakness. Stage 2 would be increased weakness to the extremities and decreased ability to complete ADLs. And then stage 3 would be severe selective weakness in the distal proportions of the extremities. And your respiratory system is going to start being affected, causing you to have fatigue and slight increase in breathing effort. And then you move on to phase 2, which is stage 4 and 5. So with stage 4, the ability to perform ADLs, but they tire very easily doing so. They develop spasticity, which is a sign of an upper motor neuron lesion, right? Increased muscle weakness, and they become mostly wheelchair dependent. Stage 5, there's severe weakness in the lower extremities and moderate to severe weakness in your upper extremities. I forgot to put it there. That's what it means, upper extremities. And they begin to be concerned with pressure sores and limited mobility at this point. So what would you suggest wheelchair-wise for this patient?
What type of wheelchair or?
Yeah, what type of wheelchair would you suggest?
I mean, more like the air cushion thing, right?
That's good. So seating would be air, but what else could we give them as in a wheelchair? It's very simple. Yes. Yeah, an electric wheelchair with what ability?
Pressure relief.
How would you provide pressure relief with an electric wheelchair? Thank you. You need a tilting space. So phase 3 is stage 6, and they are dependent bed bound and max assist for ADLs. Really probably dependent for ADLs, to be honest with you. Okay. Why don't we need a break yet, guys? Are we good? Okay. So degenerative disease interventions. So, endurance training, balance, coordination, agility training, flexibility, muscle performance, relaxation, neuro rehab, gait locomotion training, and ADL training. So with aerobic and conditioning, endurance conditioning, you want to monitor the patient's cardiopulmonary capacity, okay? Why is that important? Yes, so their breathing is impacted by the disease process. So how would you monitor the progression of the disease? The impact of exercise on their capacity, on their cardiovascular capacity, right? So if we can watch them through exercise and their response to it, and even their response to rest, we could then see if they progress through their disease process. Yes.
Will this be done through rate of perceived exertion, or through rate of perceived exertion, or some other way?
So pulse oximetry would be a good way to look at it, right? Because the capacity of the lungs is going to diminish to the point that they need a ventilator to live. So you'll see a change in their ability to maintain oxygen levels.
Just that, like,
Either, yeah, or anything, yeah. It could be just sitting at some point. It will be sitting, right? Not just with activity. But it is a good way to monitor. What I'm trying to express to you is that it's important that you monitor them. Because if you're not monitoring them through treatment, then how do we know their capacity? And how do we know how we are impacting their cardiovascular system if they have a neurodegenerative disease and they're at risk of developing what could be acute respiratory failure, right? Because it could be a delicate situation. So monitoring them is important, and it's the way to keep them safe during treatment. So we've talked about ergometers. I showed you the one at regional that have both. You do one or the other. Treadmill training. As the patient progresses through the disease process, obviously this is not going to be something that's super safe for them to do, right? Walking is always the best exercise for cardiovascular exercise. Doing your ADLs. I don't know if y'all know this or if you've seen an OT do ADLs yet at all. Maybe one day you will. But if you ever observe the whole process for a patient that has a degenerative disease like to the point that they may not be able to finish on their own. They may have to have some assistance to finish the rest of their equals. And then progressive resistance exercises. Balance, coordination, and agility training. So, you always want to do anything that's going to build their confidence level. But another way of doing balance training is vestibular training. So you want to heighten the role of the vestibular system in balance and compensate for the loss of somatosensory and visual systems. Okay? Because their vestibular system is not as impacted in most cases. So weight shifting activities with eyes open and closed, standing on or balancing on a phone, tandem walking, functional tasks that promote balance. The book has Tai Chi, don't ask me, not an expert. Throwing and catching a ball with your patient. These are all examples of what you can do to heighten your vestibular system. What does it make you think of? Remember when I told you that the components of your assessment can also be your treatment? So some of these are components of what assessment? The bird, I saw you. Yeah, so the bird and the Tonetti, right? So the components of those assessments can also be your treatments. You can apply compression to promote stability and balance. Why do you think applying weight or pressure improves balance? Think harder.
It makes them more aware of it.
Why?
Because there's weight on it, so like they have to pay attention to it.
Proprioception.
Thank you. It's making their proprioceptors more aware of where they are in space. So you want to progress the program by grading the activity to be more difficult once simpler task is accomplished. Okay? So remember me telling you about finding the right task, the just right task for the patient? And then if you find that just right task and they master it, you add a component to it, right? So let's talk about a progression. So if we're standing, we maybe add ankle weights to provide what? Stability, right? Through proprioception. So we've added those weights to help them in order to figure out somatosensory-wise where they are in space. And they master that. What can we do?
Take the weights up.
What?
Take the weights up.
Yeah, remove the weights, right? And then we are allowing them to rely on that themselves, okay? Is all this making sense, please? Okay. So, flexibility exercises. So you want to maintain or improve their range of motion and flexibility to allow for normal movement patterns, right? So, in order to remain flexible, what is an important component of that? Stretching. What if they can't stretch? Education, right? To show their family member how they're supposed to assist them with range of motion. We're be telling you education is important with this, keeping the family involved. And then you can also teach them how to do self range of motion. then there should be some nice ATP to goes on that. How to provide self-range of motion. Typically, we see that with the upper extremities. Of course, people's lower extremities are quite heavy to move themselves. You can use a leg lifter though to help in moving lower extremities. So muscle performance. So this is referring to improving your muscle strength, your power, and the endurance of your muscles. You need to accurately identify your patient's threshold, dose, and response in order to meet the patient's overall goals. So how do you find their threshold?
Test it.
Yeah, how do you do that?
MMT, but
You can do it MMT, but how can you figure out, like, what their max is?
trial and error.
Yeah, so getting them to go to their max with a certain weight, right? To see what repetition they can tolerate in order to dose the exercise properly. Do you want to give them their max to do in reps? No. No. But it should give you a better idea of what to give them for exercise if you can see what their max capacity is with the weight that you have. So, we hadn't got to MS, but one of the things about multiple sclerosis is you don't want to overheat these patients. You want to make sure that they are in a cooler environment, and if their fatigue increases or if muscle soreness is there, you need to back off. Okay. And you want to meet a sub-max threshold with your ALS patients because you don't want to over-fatigue them as well, right? Because remember, their systems are not firing appropriately, and they will fatigue much faster than most individuals. So you want to be sub-max with them. I don't know why, maybe I moved in this. We'll talk about this in a minute, but this is a suggested program for MS in your books. Okay, so the wonderful things that we've already talked about. Neuromuscular reeducation. The two wonderful ways, so NDT and PNF, okay? So NDT is what?
NDT is the one where you're doing all that you can.
Yeah, you're trying not to compensate, but you're trying to like mediate.
Yes, and how do you handle a patient with NDT? You have your hands on them, you are in their
Constantly
space, right?
Like when you have Meg walking.
Constantly cueing those muscles to do what you want them to do and inhibit what you don't want them to do. PNF, I think you've mastered it at this point, hopefully. Right? But did you notice there's a component of MDT in PNF when you have to keep your hands on the patient and you're providing input throughout the movement? Cool thing to think of. So when you talk about gait or locomotion training, you're gonna worry about the patient's balance, their speed of movement, how strong they are, what their manual muscle test is, right? And then their endurance level, how long can they make it safely, right? You have to gauge all of those things in order to know how far am I pushing this patient? Why am I pushing them this far? Is this appropriate? Is this safe? So Miss Ann is gonna go over after lunch that cycle, that gait cycle that I made you do the assignment on. Just to kind of reiterate what normal gait cycle looks like, so that you can understand what abnormal would look like. And abnormal is gonna be something that's not normal, right? So if you can know what normal looks like, you're going to be able to identify what abnormal looks like, okay? And if someone is rigid, they're gonna have a hard time moving through a gait pattern correctly, right? Because they're gonna have those antagonists and agonists working against each other during movement. So when that happens, say, it might be better to do examples later once we've talked about it. We'll do later, okay? But anyway, the importance of it is if you know what's normal, you're gonna understand what's abnormal, and you're gonna be able to correct what's abnormal, right? Because you're wanting to promote what is more of a normal movement pattern through those phases of gait. And if you can analyze someone's gait and figure out what components are wrong, you can work on musculature in order to promote normal movement patterns. Does that make sense?